I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the pumpkin spice latte flavoured primary care pod from Red Whale.
The primary care pod from Red Whale.
So grab your preferred drink of choice, which might be a pumpkin spice latte, or your trainers, clutch your pearls, and let's start with the headlines. Here's what's coming up this week. I think I'm losing my hair. How to approach alopecia consultations. Alopecia is one of many distressing conditions that patients may have to pluck up the courage to ask us about. Having a framework to help us approach topics such as this can be really useful.
Building on last year's successful programme of pearls designed for GP trainees, we're back with another season of Red Whale resources to support the next generation of GPs and their supervisors. We start with workplace-based assessments, demystified.
And here's what's coming up next week. Idiopathic nephrotic syndrome is the most common paediatric glomerular disease. Despite this, we won't see it very often, but a quick reminder might help us spot it.
Named after an octopus trap and sometimes called broken heart syndrome, Takotsubo cardiomyopathy is being diagnosed more frequently. In fact, 2% of people initially labelled as having acute coronary syndrome will end up with the diagnosis.
So let's start with alopecia. Now, this one took me 11 minutes and 2 seconds to read, so a good solid start to the episode. What did this one mean for you, Ali?
Well, I'm really pleased we're talking about this topic because, as you mentioned in your headline, Nick, I think we've all met patients who are incredibly distressed by hair loss. Hair's often a big part of people's confidence and their identity. And so these consultations can be quite fraught emotionally. And I think for that reason, it's really useful for us to have a clear framework in our minds of how we're going to assess and approach the problem of hair loss.
Yes, exactly. And this pearl is designed to help build the framework that we can have in our minds so that it all just seems quite seamless when it happens. So we're going to consider scarring versus non-scarring and why that matters, how spotting patterns can help us make the diagnosis, and management options and when to refer. Now, differentiating between scarring and non-scarring alopecia is important because scarring alopecia is irreversible, so early intervention is required to minimise hair loss. We're going to look at some of the diagnostic clinical features to help us distinguish which cases we can manage in primary care and which need prompt referral. We'll also look at some primary care management strategies for alopecia areata using information drawn from, amongst others, a British Association of Dermatologists guideline from 2012, a JAMA clinical update from 2021, and the Primary Care Dermatology Society guidance accessed in December 2020. And the full references, as always, are in the written pearl. So, Ali, can you set us off with an approach to diagnosing hair loss?
I can, Nick. So as you've mentioned it a couple of times so far, the first thing we're going to consider is this question of, is it scarring or non-scarring alopecia? And then for non-scarring alopecia, we're going to consider what the pattern of hair loss is. And just to reiterate what you said, Nick, the reason that differentiating between scarring and non-scarring alopecia is important is because scarring alopecia is irreversible. So early intervention is needed in that group to minimise progression and so minimise hair loss. So with scarring alopecia, what we commonly see is inflammation, and the scalp can look atrophic and shiny. And in long-term severe cases, we can see something called doll's hair tufting. So if you think of the hair on a toy doll's head, do you know how you can see it's been sort of drilled in by a machine in clumps? That's the appearance we're talking about. And if you're confident with dermoscopy, then if you have a look, you'll see loss of follicular openings, and the follicle heads may have a black clubbed appearance. And then conversely, with non-scarring alopecia, we won't see any of that inflammation, we won't see atrophy, we won't see doll's hair tufting. And with a dermatoscope, you'll classically see preserved follicular openings.
If we establish that we're dealing with non-scarring alopecia, then the next step is to look at the pattern of hair loss. Male pattern hair loss has recession of frontal hairline in a triangular pattern, followed by thinning at the vertex. Female pattern has diffuse thinning of the centroparietal region, and if this is associated with hirsutism or other signs of virilization, then consider hyperandrogenism. Diffuse hair loss has widespread thinning of hair growth across the whole scalp. Patchy hair loss has well-rounded, discrete patches of hair loss. Now, All Things Medical have a list of differential diagnoses. So what are the differentials for alopecia, Ali?
Well, the differential diagnoses for diffuse hair loss are age-related hair loss, drug causes such as chemotherapy, telogen effluvium, hormonal disorders, commonly thyroid, iron deficiency anemia, or other nutritional disorders such as zinc deficiency, and one that I don't think I've been considering in alopecia consultations up to now, which is secondary syphilis.
Well, no, I hadn't been considering that either. That's something for my learning plan. Now, telogen effluvium can be triggered by childbirth. It can also be triggered by a major life event, marked weight loss, including extreme dieting, and severe trauma or illness. Now, when I was 24, on my elective in Australia, I went whitewater rafting, and it was a day that I'll never forget because everything changed in an instant. In a terrifying turn of events, I nearly drowned and ended up getting leptospirosis. Now, every day since then has been a blessing, and I'm acutely aware of how lucky I am to still be here for so many reasons. But that's a whole podcast in itself. Now, the reason for mentioning the leptospirosis is that once I thought I was over the worst, all my hair fell out in a matter of weeks. I'd wash my hair and the foam would be not the usual white, the foam would be black because of all the hair that was in it. And it completely destroyed my confidence. And the lengths that I'd go to try and help is, when you look back, it was just pathetic what I was trying to do. I remember at one point, I think I only had about 3 strands of hair left and I bought a volumizing spray. What was I thinking? I mean, literally. And I would spend hours before I would leave the house trying to style these 3 strands of hair, hoping that nobody would notice. But of course they did. And people can be really cruel when they want to be. And none of the doctors I saw told me what it was, and that telogen effluvium usually resolves completely without any treatment over several months. So as you can imagine, I really needed to hear that. So if you see a patient who has telogen effluvium, then please reassure them that it's likely to get better. And thankfully it did for me, but it was not a nice time, I have to say.
Well, Nick, I'm so sorry to hear that you went through all of that, and thank you for sharing it with us. If you make your whole other podcast, by the way, about that story, then I definitely want to listen to it.
It might be a long one.
Yeah. I'm definitely going to keep that point you made in mind. That's such a valuable one about how useful reassurance is when I next meet somebody with telogen effluvium. Thinking then again about our differential diagnoses for hair loss. The differential diagnosis for patchy hair loss includes alopecia areata, trichotillomania, which is where people experience an uncontrollable urge to pull or twist their own hair until it comes out. And in that condition, there are often frontal and temporal and unusual shaped patches with mixed ages of regrowth. And then a final differential for patchy hair loss would be traction alopecia from things like tight braiding. And the differential diagnosis for scarring alopecia are tinea capitis, which you'll usually see associated with scale and inflammation, discoid lupus erythematosus, lichen planopilaris, scleroderma, and other more rare causes, pemphigus and erosive pustular dermatosis. So how do we assess alopecia, Nick?
Well, Ali, the first thing that we need to do is to look for evidence of hair regrowth. Now, this will affect management choices later. So we should ask about triggers, emotional stress, acute illness. Have there been any new medications? What about diet and nutrition? These are all important things. And we should also ask about the impact on mood and quality of life. We should check regarding a family or personal history of atopy and autoimmune disease. We should consider full blood count, ferritin and TFTs in all and wider bloods for hormonal or autoimmune conditions where they are relevant. We should also consider skin scrapings or swabs where relevant as well. So let's spend some time talking about alopecia areata now. This is a chronic inflammatory condition of the hair follicle causing patchy, non-scarring hair loss. It most commonly affects the scalp, but it can affect the entire body.
Yes, and looking at the features of alopecia areata, it's typically sudden onset, sometimes with further patches appearing 3 to 6 weeks after the first ones, and new patches can appear in a cyclical pattern. Regrowth is pretty unpredictable, which can be really hard for patients, so the hair might regrow within months, or the hair loss might be more long-term. And exclamation mark hairs may be visible. These are the short, broken hairs around the margins of alopecia patches. The skin at the sites of hair loss in alopecia areata is usually smooth and healthy looking with a normal colour, or it might be possibly slightly pinkish. And usually the condition is asymptomatic, although occasionally the skin may tingle or itch or burn. Dermatoscope examination may show yellow or black dots on the skin where hair has broken off. It might show coiled pigtail hairs, and it might show exclamation mark hairs. And there are nail changes in about 10% of people with alopecia areata, with pitting being the most common.
The management of alopecia depends on the clinical context and the underlying cause. So for alopecia areata, we need to advise patients that hair will usually regrow within a year. However, prognosis is worse the more extensive the loss. Treatments may help trigger regrowth but cannot cure the condition, and most patients will experience further episodes. They should use sunblock. We should signpost to cosmetic treatments such as wigs, and these can be purchased privately or prescribed in secondary care, though the patient will still have to pay a considerable amount, unfortunately. We should also offer counselling and psychological support where appropriate. If there is visible regrowth, then no treatment is needed. And if there is no regrowth and hair loss is less than 50%, then watchful waiting is the recommended plan. If there is no regrowth and hair loss is more than 50%, then we consider treatment. This is either a potent or very potent topical steroids for 3 months and not to be used on the face. Steroid-sparing agents such as topical tacrolimus can be considered for facial hair loss.
Yes, and then thinking a bit more about alopecia areata, we would refer if there was no response to topical treatment, if we were uncertain about the diagnosis, if our patient was pregnant or breastfeeding, and we'd also refer any alopecia in a child because onset in childhood carries a poor prognosis for recovery. And the need for emotional support is another indication for a referral, and so would be the desire for a wig. And treatment in secondary care might include intralesional steroids. These are usually used first line. And other options include dithronol, which is often used second line in persistent disease. And the aim here is to induce a low-grade dermatitis. Topical immunotherapy is also sometimes used, again with an aim to induce low-grade contact dermatitis that stimulates hair regrowth. And interestingly, the more extensive the hair loss or the longer it's been present, the less effective immunotherapy is likely to be. And then topical super potent steroids are another treatment option in secondary care, often used under occlusion, or less potent steroids in the form of a foam, although there are only small trials showing limited effectiveness to support this. And what about systemic steroids, Nick?
Well, one tiny RCT showed that 1/3 of patients responded, but relapse rates were high. They're rarely used because of the systemic side effects, and that's from the BMJ in 2010. Now, minoxidil is an option. We might have heard of this in relation to male pattern baldness. It's not available on NHS prescription and it's expensive over the counter. Treatment may take 6 months to show benefit, and any effect will rapidly be lost if treatment is discontinued. It may be most beneficial in preventing relapse rather than to induce hair growth initially. Systemic immunosuppressants such as azathioprine, cyclosporin and methotrexate could also be used off licence, but just to reiterate, these are all treatment options that would be started in secondary care.
Yes, and that takes us to the biological drugs. So there is a drug called baricitinib, a JAK inhibitor, which showed some promising results in phase 3 trials with almost 40% of patients achieving 80% scalp hair coverage after 8 months, with a low side effect profile. And that's from data published by NEJM in 2022. But last year, NICE recommended against the use of this drug baricitinib for alopecia areata in a technology appraisal. They said this was due to high cost and the need for long-term prescribing to maintain the benefits. However, there were a few patients who started on NHS-prescribed baricitinib before that NICE publication, and NICE said they may continue with it, so we might come across the odd person on this.
Scarring alopecia should result in a prompt referral to secondary care. Treatment may include intralesional steroids, antibiotics, antifungals, retinoids, and immunosuppressive therapies. For female pattern hair loss, minoxidil may be advised privately. Oral treatments such as spironolactone, cyproterone acetate and cimetidine may be considered off-licence, but it should also be said that there is no evidence of effectiveness for these treatments.
And so for male pattern hair loss, there are a few options. 5% minoxidil lotion is licensed in men, but as Nick mentioned, it's not available on NHS prescription. Finasteride at a dose of 1 milligrams is licensed for the treatment of androgenic alopecia, but again, it's only available via private prescription and not on the NHS. But some of our patients may be getting hold of these from online pharmacies or high street pharmacies who run hair loss programmes for men. And with finasteride, it can stop hair loss, but only for the duration of treatment, and it's not without systemic side effects. It can cause erectile dysfunction and reduced libido, although these are actually often transient, but it's also been associated with depression. And actually on that association with depression, in 2017, the MHRA issued an alert saying that all patients taking finasteride 1 milligrams for alopecia should be advised that if they develop depression, they should stop treatment immediately and inform a healthcare professional.
So thinking about patient resources in alopecia, there are some really useful resources for patients in the written Pearl, and we'll also put a link to those in the show notes. Now, they are for Alopecia UK and also the British Association of Dermatologists resources on alopecia areata, female pattern hair loss and male pattern hair loss. So here are your learning points for alopecia. Scarring alopecia requires prompt referral to secondary care as hair loss is irreversible. Consider whether the hair loss is patchy or diffuse, as this will help in diagnosis.
Alopecia areata causes patchy, non-inflamed hair loss. Visible regrowth may be present. Treatment of alopecia in primary care includes reassurance and education. Topical steroids may be used in some cases.
We should refer people with alopecia areata if there is no response to topical steroids, the diagnosis is uncertain, the patient is a child or a pregnant or breastfeeding woman, or if there is a need for emotional support and or a wig. How are you doing, Ali?
Yeah, I'm very good, thank you, Nick. It's nice to be back. I very much enjoyed my first episodes with you back in August. I got a fairly strange... I did. Yeah, I got a fairly strange piece of... thank you. My 8-year-old gave me a strange piece of feedback after those episodes, though. So he listened to you and me do the headlines, and he was in absolute hysterics. And I asked him why, and he said, "Mummy, you said fart on the podcast." So it turns out what it was. I need to enunciate the C sound a bit better in myocardial infarction. So it's infarction, not infarction. So that gave me a little laugh. And something else that has been giving me a good old chuckle last month when I was listening was the messages that our listeners have been sending in about where they're listening from and what they're doing. I particularly enjoyed the person who told us about stumbling onto a nudist beach. So basically, my request is somebody to top that. Okay. Where are you and what are you doing, please, while you listen? But please do keep it broadcastable.
Yes, thank you. Good question or good point. So please send us a text message telling us who you are, where you are, and what you're doing, just look at the episode blurb in your preferred podcasting platform and press where it says send us a text message. Now, if your phone plan includes text messages, then a text to us is included in the plan and it won't cost you anything extra at all. Otherwise, it's just like sending any other text message and it's charged at your standard network rate. Now, there are lots of people listening all over the world. So I also need to say that if you are abroad when you text us, and when I say abroad, I mean away from the country that your phone is registered in, then it's like sending any other international text message. But if you're sending a text message in the country that your phone's registered in, it's just as normal. So there we go. Deep breath. So Pearl 2, and we're moving on now to workplace-based assessment, WPBA, and we're going to demystify that now. So this one took me 23 minutes and 22 seconds to read, so quite a long one. Definitely a latte and a cinnamon bun. So what did this one mean for you, Ali?
Well, Nick, I finished my GP training 7 years ago, and I still have a recurring nightmare that I'm a GP trainee again and I'm on my way to an ARCP panel and I suddenly realise there's loads of assessments that I haven't completed. And so that probably tells you everything you need to know about my relationship with the e-portfolio. The phrase we use in the Pearl is that the process can be baffling and overwhelming, and I really relate to that. So yeah, I think the Pearl's really useful. It does demystify this process, and that's a very valuable thing. And I would say as well, even if you're not a trainee or a trainer, I think this section is still worth a listen, because unless you qualified very, very recently, things have probably changed a bit compared to when you were a trainee. And I think it's good for all of us to have a rough sense of what it is that GP trainees are expected to do.
Absolutely. Now, all the time I was reading this, I kept thinking, I wish I'd had this when I was a trainee. My life would have been so much easier. And I think my relationship with my training process is a bit further away than Ali. So we didn't have an e-portfolio back then. But equally, all the different hoops to jump through, I did find incredibly stressful. So this is so lovely to kind of have a guiding light, a beacon of hope to get you through the process. So why did we write this resource, really? Well, our Red Whale program directors and GP trainers work in various schemes across the UK. And until recently, I was a GP trainer myself. Now, of course, the different training schemes across the UK may be organised and run differently, but there are some common ways that trainees need to manage their time. Now, one of these is completing all the necessary steps for the portfolio to achieve the Certificate of Completion of Training, or CCT. And as Ali said, it can feel baffling and overwhelming. So we got our Red Whale training heads together, read through the RCGP guidance, got hints and tips from our trainers and program directors, and put together our demystified resource. Now, we hope it's useful for trainees, but also GP trainers and GP colleagues who support trainees in their learning. As Ali was saying, it's useful for everyone. And we really recommend that you have a proper read of it. And we hope that you enjoy using this resource and find it a valuable tool throughout your GP training, or indeed, if you've completed your training, to help you support trainees that you are in contact with. And like any good educator, our program directors would welcome feedback. So this is where you come in. This is your chance to influence what we do. So please let us know how we could improve these resources and what other resources you would value to support you with your training. And remember, goalposts can change frequently. So for the most up-to-date information on this topic, then we should always look at the official MRCGP website, and we'll put a link to this in the show notes.
Yes, so the main part of this resource is a map to guide you or help you guide trainees over the 3 years of training. This includes the elements of the workplace-based assessment that are required to achieve your annual review of competency progression, ARCP, for each year. And we've based this guide on a full-time trainee completing training over 3 years. So if you're less than full-time, you'll need to adjust this pro rata. But before we dive in, we need to talk about acronyms, because there are a lot of these, aren't there, Nick?
Yes, tell me about it. And just from what you've said, we could have had the ARCP as the annual review of competency progression, and also less than full-time is LTFT. So all of those things. And I had to say that it was the acronyms that were beginning to increasingly drive me around the bend as time went on when I was a trainer.
Yes, so let's demystify these for a start. And some of them are easier than others, and you'll probably know lots of them already.
But you know that when you go to a party and there's someone there that you really should remember the name of, but it's gone beyond that point and it's too embarrassing to admit that you don't know their name. Well, some acronyms in GP education are a bit like that. So think of us as being your understanding friend that's here to save you from the embarrassment of having to ask what something stands for.
Okay, so let's rattle through these. AED is automated external defibrillator, and BLS is basic life support. I knew those.
Excellent. I knew those two, so that's good. We're off to a good start.
Well done.
Let's see how far we get now. So CCR is clinical case review and COT is consultation observation tool.
Okay, and ESR is educational supervisor report. LEA is learning event analysis.
Mini KEX is mini consultation evaluation exercise and MSF is multi-source feedback.
PSQ is patient satisfaction questionnaire. And QIA is quality improvement activity.
Whereas QIP is quality improvement project and SEA is significant event analysis.
And finally, UEC is urgent and emergency care, and WPBA is workplace-based assessment. And we'll now explain all the necessary components of the WPBA arranged alphabetically. Well, we had to find some way to arrange things logically. If you've got a better way, then we'd love to hear it.
Yes, we would. But in the absence of that for now, we're doing it alphabetically. So let's start with basic life support with an automated external defibrillator, so BLS/AED. Now, from August 2022, trainees have been required to have evidence of hands-on BLS training with AED for adults, children and infants. If trainees have attended an ALS, so Advanced Life Support course, they are usually issued with a certificate for 3 to 4 years. For clarity though, even if a trainee has attended an ALS course, BLS and AED training will still need to be updated every 12 months by attending an appropriate course with evidence logged in the portfolio. Certificates should be added to the portfolio as supporting document and be linked to the compliance passport section. And when logged correctly, it will show as up to date in the compliance passport section.
So next up, we have the Care Assessment Tool, or CAT, and this applies to ST3 year only. So the CAT or CAT replaces case-based discussions in the ST3 year. And the CAT includes case-based discussions, but also encompasses evaluation of wider capabilities that demonstrate professional judgment. The RCGP has suggested that CATs can be any of case-based discussions, as was done in ST1 and ST2, random case reviews, leadership activities, prescribing assessment follow-up, consultation assessments, which are not COTS, referrals review, or others such as debriefs, review of investigation or imaging use, or follow-up of a quality improvement project.
Now, Ali mentioned case-based discussions there, so let's look at case-based discussions, CBDs, in more detail. Now, these are structured oral interviews that assess a trainee's professional judgment by reviewing a case that a trainee manages independently. So our tips are that the case should be written up and shared with your supervisor before the assessment. The supervisor will then spend up to 30 minutes discussing the case with you and triangulating it with the portfolio capabilities. The RCGP has produced useful question generators for supervisors to use, and these are also useful for trainees to get an idea as to the type of questions that they may be asked. Now, there are themes of questions for GP supervisors and hospital supervisors to consider. Trainees are encouraged to submit cases that cover the breadth of the capability areas as well as cases with varying complexity.
And next we have clinical examination and procedural skills, or CEPS or KEPS, depending on how you prefer to pronounce it. Guidance for CEPS has recently been updated, so we'll put a link to that in the show notes. So over the 3 years of GP training, all trainees should demonstrate capability in a range of examinations. The GMC mandates that competency in 5 intimate skills must be signed off, and the educational supervisor would also need to assess a range of other skills and sign off the trainee as being competent. So the GMC mandated intimate skills, which must be signed off as competent, are examination of the breast, prostate, rectal examination, male genital examination, and female genital examination. And then the RCGP suggestions for the 7 systems or patient groups to be assessed by SEPS, and a range of these should be demonstrated and signed off, are respiratory, ear, nose and throat, abdominal, cardiovascular, musculoskeletal, neurological, and children aged 1 to 5 years.
Now, of course, we have some tips for this, so don't worry, here we go. Firstly, prioritise being signed off for all the intimate skills and as many of the suggested skills as possible in order to demonstrate broad competency. The RCGP guidance states that being graded as able to complete unsupervised, in inverted commas, in all of the 7 system SEPs, in addition to the mandatory SEPs, would provide strong evidence of competency and strong evidence that a trainee has met the SEPs requirement for WPBA.
So consider how you might do this. Things like joint clinics with your supervisor or outpatient opportunities, and pace yourself through the 3 years. So you should be completing some relevant to post SEPs in each training year, ST1 and ST2, because without this you would not meet the requirements for ST1 or ST2. And a suitably trained professional will need to observe and document your performance on a SEPS evidence form. If it's a doctor who's not a GP, they need to be at least ST4.
Onto the consultation observation tool, or COT, next. Now, COTs can be done for any of the following type of consultation. So either in-person live or in-person recorded, or virtual consultation live or virtual consultation recorded. And there's also the audio COT as well. Now, COTs are carried out during a GP post. Your supervisor will grade each section of your consultation and provide feedback and recommendations. It's encouraged that trainees do a mixture of different types of consultations for their COTs.
And moving on to the Clinical Supervisors Report, or CSR now. For non-primary care placements, each post requires a CSR. And for primary care placements, a CSR is only needed if your clinical supervisor, or CS, is different from your educational supervisor, or ES, or if more evidence is required prior to your ESR. In this case, your CSR could provide the missing evidence and should ideally be done by another CS from within the practice. If this is not possible, the ES will complete the CSR. The key difference here is that in non-primary care, for example, hospital placements, trainees are assessed against the expected level for a GP trainee at this stage in training. However, in primary care placements, trainees are assessed against a trainee at the point of Certificate of Completion of Training, or CCT.
Next up, we have Educational Supervisors Review, ESR, and an Educational Supervisors Review is completed twice a year. At the midpoint of the year, if the trainee is progressing satisfactorily and everything is on track, a shorter interim ESR review can be completed. If there are any concerns about the trainee's performance, or they have had either an unsatisfactory or developmental outcome in their previous ARCP, then the full ESR will be required.
Leadership activity now. So this is an activity undertaken during the ST3 year. Following this activity, a leadership MSF should also be conducted in the second half of the ST3 year to receive specific feedback on leadership skills. And examples of leadership activities given by the RCGP are chairing a meeting, and you'll find a handy article to help with this on Red Whale Knowledge, a quality improvement project. Many of our articles suggest ideas that might inspire a quality improvement project, a wellbeing project to enhance the wellbeing of the practice team, creation or review of a clinical protocol. You could look at our range of GEMS documents for inspiration there. That's guidance and evidence made simple. And you could look at practice leaflet review or website design review. Or you could do a fresh pair of eyes exercise where the trainee reviews the practice organisation from an objective viewpoint. Or as a trainee, you might have your own idea for a leadership activity, and that is fine too. You can find more information about examples of leadership activities on the RCGP portal.
And now let's talk about learning event analysis, so LEA. In each training year, at least one learning event analysis should be undertaken. These are events where lessons can be learned, but they don't necessarily meet the threshold for a significant event analysis where they reach the GMC threshold for harm. The LEA should be written up and shared with the team, and trainees should also reflect any further learning and development in the PDP.
And time now for learning logs, including CCRs. So trainees should have a range of log entries that are about patients they have seen. The majority should be logged as clinical case reviews or CCRs, aiming for at least 3 CCRs a month, although that would be pro rata for less than full-time trainees. In addition, other learning logs, for example, supporting documentation, can be recorded to demonstrate evidence of capabilities such as organisation, management and leadership. A great tip here to make it easier for your ESRs is that each capability should be covered at least once in each 6-month review period. The RCGP has produced a helpful guide with worked examples of different log entries with supervisor examples included.
That's good to know. So let's consider mini consultation evaluation exercise, mini KEX, next. A mini KEX is an assessment during a hospital post where a trainee and patient interaction is observed. It's the equivalent of the COT, which is undertaken during a GP post. Like a COT, it should cover a range of capabilities. It's recommended that the mini KEX assessment is carried out by your hospital clinical supervisor, but it could also be completed by doctors who are ST4 or above, or specialty and associate specialist doctors with equivalent experience and who have met the GMC assessor requirements.
Okay, and on to multi-source feedback or MSF now. And this is something that continues even after you've completed your training, so it's still in our lives now, isn't it, Nick?
Yes, certainly is. There's no escape from MSF, the bane of most of our lives, I'm sure.
So trainees are required to do an MSF in every year of training. Each MSF should have a minimum of 10 respondents, 5 of whom are clinical and 5 non-clinical. This is anonymous feedback, enabling you to view your colleagues' opinions on your clinical performance and professional behaviour. Hopefully, it's a positive experience for you and doesn't turn into an episode of The Traitors with you trying to work out who has said certain things about you.
Yes.
Following the MSF, trainees should review the data and reflect on what their next steps might be. A good tip here is to be proactive with the MSF and don't leave it until the end of your post. This will give you adequate time to get enough respondents and will also provide an opportunity to discuss and reflect on the feedback with your supervisor. Your trainers and programme directors will have gone through lots of MSFs for trainees over the years. And we joked about negative feedback there. You know, most of the time comments are positive and constructive and it is a positive experience, but some unexpected feedback can occasionally be received, and discussing your thoughts about the feedback with your supervisor is just as important as receiving it from others. And during the ST3 year, there will be an additional leadership MSF that is done after, as we mentioned, after the ST3 leadership activity.
Placement planning meetings. Now, these meetings should be done at the beginning of your post with your named clinical supervisor. This is a great opportunity to look at any educational objectives for the post, in addition to a discussion to identify the specific opportunities that would be relevant to primary care. Some schemes have 2 times by 6 month rotations, while others have 3 times by 4 month rotations. So it's important that a placement planning meeting is held with each new named clinical supervisor. And I would probably advise that you as the trainee, if you try and instigate that and get it in the diary so that it happens, rather than breathing a sigh of relief if it doesn't happen and think I've gotten away with that. It's really important to get that done and written up.
Yeah. And then thinking about the prescribing assessment. During the ST3 year, a prescribing assessment which reviews 50 retrospective prescriptions and includes a reflection on any potential errors should be undertaken. And a tip we really love here is to make it simple to find the prescriptions trainees have generated. And did you know that EMIS, System 1 and Vision have inbuilt tools to automate the search and make it not a laborious process? You can find the information, guides and templates for doing that on the RCGP site. And a prescribing assessment can actually be really helpful too. Trainees can benefit from identifying their personal prescribing trends, reflecting on errors and putting learning plans in place to improve future prescribing.
And moving on now to a different kind of questionnaire. We talked about MSF before, so now on to Patient Satisfaction Questionnaire, PSQ. And the PSQ provides the opportunity for patients to provide feedback on empathy and relationship building skills during consultations, and one should be undertaken after the midpoint of the ST3 year. A PSQ can be done electronically or in paper form and uploaded to the portal by a practice administrator. They comprise 9 questions that patients are asked after their consultation with the trainee, and each question has 5 options for them to choose from. 34 responses are required for the PSQ to be completed, and it can then be discussed with your ES to plan any action or celebrate the feedback, which will be a lovely thing to do. But yeah, 34 responses. Remember that it can take a little bit of time to get that done. So just give yourself enough time to do it.
Yeah, the PSQ is another thing that remains with you post CCT, doesn't it? And it's it always surprises me how hard it is to get all those responses. Yes, and moving on, it's the quality improvement activity next. So the GMC requires that all doctors, again, another one that carries on post-training, demonstrate involvement in a quality improvement activity at least once a year. So during GP training, a quality improvement project or QIP should be done during the ST1 or ST2 year, and Nick's got more on that in a minute. QIAs should be done in the years in which you don't do a QIP. Having said that, we generally advise our trainees to get involved in some form of quality improvement regularly, and this can be carried forward post-CCT into your future years as a GP. The RCGP has a detailed description of what types of activities could be undertaken for QIA. These all involve taking action as a result of data. So they suggest things like a review of personal outcome data through case reviews, such as a referral review, or involvement in a large-scale national audit with data collection at an individual or practice level, or small-scale data searches, which could include reviewing prescribing separate to the prescribing assessment, or a small specific quality improvement using the Plan, Do, Study, Act or PDSA cycle, or writing or revising a practice policy, a monitoring and evaluation exercise such as looking at patients on DMARDs or warfarin, or search and do activities involving information collection and analysis. And the RCGP does note that an LEA, reflection on feedback or a leadership project do not count as mandatory quality improvement activities.
And staying with quality and on to quality improvement projects, so QIP. During the ST1 or ST2 year, a quality improvement project should be undertaken while in a primary care placement. QIPs should have a clear aim, data collection, sufficient engagement with the team and other stakeholders, and a reflection on the changes or what was learnt. And our tips for this would be to identify a need in your training practice and then use the model for improvement suggested by the RCGP. And you can find details of this in our Red Whale Knowledge article, Improving Your Practice. If you're struggling for ideas for your QIP, then look at some of the gems on Red Whale Knowledge for inspiration.
Okay, and on to safeguarding now, both child and adult. So at the beginning of ST1, trainees will usually complete a level 3 adult and child safeguarding course, and evidence that this is complete needs to be logged in their portfolio. This will be valid for 36 months, and it requires updating if a trainee extends training for any reason. Now, a top tip here is we advise our ST3s to formally complete this again towards the end of training before CCT to ensure it carries you over your CCT period. And in addition, every 12 months, all trainees need to have a safeguarding knowledge update and at least one clinical case review. Both of these must be documented in a learning log entry. It's recommended that these are linked to the clinical experience group, people with health disadvantages and vulnerabilities. And a safeguarding knowledge update could be demonstrated in a few ways: attending face-to-face training, attending webinars, attending safeguarding practice meetings, completing e-learning, or repeating the level 3 safeguarding training. When documenting the knowledge update within the learning log entry, it must include a demonstration of knowledge gained, key safeguarding information discussed, and appropriate action to take if there are any concerns. And the clinical case review could be a patient interaction that demonstrated the application of safeguarding knowledge. It could be group case discussion, for example, at a VTS, or it could be discussing a case at a practice safeguarding meeting.
And finally, we have significant event analysis, SEA. Now, if a significant event occurs that meets the GMC threshold of potential or actual serious harm to patients, this should be logged in the portfolio and declared on the Form R. This should also be considered for any fitness to practice issues. Our tip here is to always discuss cases that you are unsure about with your educational supervisor, and if still in doubt, it's always better to declare a significant event and go through the analysis.
So if you made it this far, phew, well done. If you have a look at the written Pearl, if you've not done so already, then there is a roadmap for each year of training with a suggestion of how you might be able to fit all of this in. And there are a few assumptions we've made here. Firstly, the roadmap guide is for a full-time trainee. So if you're less than full-time, the information telling you what you need to do when needs to be considered pro rata. And in addition, the roadmaps are designed for 2 6-month posts for every training year. So again, this will need adjusting for your local scheme if it's different.
So we're going to go through some tips now for the different ST years. So the biggest tip for our ST1s is to get to grips with the portfolio early on so that you can maximise the educational benefit and avoid rushing through outstanding assessments towards the end of the year. So meet your educational and clinical supervisors early and ensure that they are linked to you on your portfolio. So what do you need to complete in your ST1 year? Now, I know it might seem very daunting, but don't panic. Our Redwell trainers and program directors have come up with a suggested guide to help you through with the least amount of stress and the maximum benefit. So take a deep breath and take a look at the written Pearl. It's all there for you with a month-by-month guide on what you need to do for your WBPA, plus any other assessments that you need to do as well, plus suggested session timings for you, or to cut to the chase, how long do we suggest your appointment times need to be? Now, what's the one thing that jumps out on me when I read it? Well, those learning logs. You need to do 3 or 4 a month. If you get into the habit of doing these early on, then the whole process will be a lot less painful.
Yeah, I agree. That's absolutely key with those learning logs and getting in the habit of doing them. And then thinking onto your ST2 year. So by this year, you've hopefully got the ball rolling with your portfolio, and you should now be aware of any gaps within your capabilities and competencies. So with your learning logs, focus on the areas with gaps and look to evidence the capabilities and competencies as best you can to provide an even distribution of evidence as you complete this year. Everything you need to do to get through the year is in the guide in the written Pearl, so do take a look.
And finally, we have your ST3 year, the last year of training before CCT. If that's you right now, how are you feeling? Are you excited? Are you apprehensive? You might be both of those, and that's okay. But if you think that you're struggling, then there's absolutely no shame in that whatsoever. But I'd recommend seeking help from your trainer and program directors sooner rather than later. Now, this is quite a busy year, so plan it early and discuss your plan with your trainer at your placement planning meeting. Think about any gaps that you may have in your evidence, and have there been any issues in your ARCP that you can learn from? Aim to distribute the WBPA capabilities through each month of training to ensure a smooth and unrushed finish. It's all there in our guide in the written Pearl. Now, one tip that leapt out at me was the advice to work towards 10-minute appointments, so 15 to 18 patients per session. Now, most GP trainees will complete training consulting at 10-minute intervals, and this would make the transition easier after CCT. But you may need to have catch-up slots in your session to achieve this, and that's absolutely fine at this stage, no problem with that at all. So here are your learning points for work-based place assessments demystified. Plan your GP training over 3 years.
To get the most out of training, don't leave all your workplace-based assessments towards the end of the year.
Use the tables in the written Pearl as a guide to support your planning. Time now for our primary care superheroes.
So thank you for all your texts that you've sent in. 4061 on the text says they're listening in Bristol. 3580 on the text says, I'm a paramedic and TACP in urgent and emergency care, and I'm listening to Reds whilst out for a 5-mile run. Love the show, David. Thank you very much, David.
Yes, thanks, David. 8807 on the text. It says, GP in Essex, currently walking in Epping Forest, ! We have to have a winner. We've got a winner for this month, and it is 0484 on the text. Just thought I'd say a quick hello from the sky! Listening to the Red Whale pod in an aeroplane on the way to Barcelona, where I am dropping my daughter off at university. Love the shows. Keep up the good work. From Kate, GP working in the military. And if it was possible, that would definitely be a mic drop. So thank you for that, Kate. Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. And how do I become a member, I hear you ask? Well, if you're listening to us, then you are part of the pod. So welcome. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter your code, which is Red Whale Pod, to get 10% off. Here's the small print. The discount is only for this product and it won't work on anything else, no matter how hard you try. I know what it's like with those vouchers. You Google them, you try them for a discount. It's not going to work for anything but this. And please also note that this voucher code is all one word and it's all lowercase, so it's Red Whale Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. If you can spare a little more time, then please leave us a nice review. Because of the way the algorithms work, it means that other people just like you can discover us.
Of course, putting algorithms aside, there is no greater recommendation than a word-of-mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcast platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. If you want us to see something about the podcast, then please use the hashtag RedWhalePod.
And the other thing that you can do, if you click on the link in the show notes, then you can leave us a voice message telling us about anything that you found helpful or would like us to go over.
Yes, and you can also email us. Our email address is podcast@red-whale.co.uk. Until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work, so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.